Hello, welcome to the information session for the ACT Primary Care Pilot. My name is Kate Eigner. I'm Manager of Quality Improvement here at Capital Health Network. And joining me today are Emily, if you'd like to introduce yourself.
Thanks, Kate. I'm Emily De Alvia. I'm part of the project team working on the primary care pilot from the ACT Health Directorate.
And Kirsty.
Hi, thanks, Kate. And my name's Kirsty Cummin. I'm working for Canberra Health Services, and I'm the Integrated Care Program Director, where we have the Liaison and Navigation Team, or LAN service.
Thanks, Kirsty and Emily. So just to let you know that this session is being pre-recorded, as the expression of interest will be open for a number of months. So any questions that you have after following this session can be submitted by email, and we'll share that email later in the presentation. And then any questions will then be added to the FAQ document, which is a living document, and that can be found on the tenders page and will be updated every Thursday. So before we start, I acknowledge the Ngunnawal people, who are the traditional custodians of the land of which I am on today, and pay my respects to their elders past, present and emerging. I recognise their ongoing contribution to our region and communities and their connection to land, water and culture. We also acknowledge and welcome all other First Nations people watching this information session. So now we'll get Emily to come on and just give a quick overview, or not a quick overview, an overview of the ACT Primary Care Pilot.
Thanks, Kate. As I said before, my name's Emily and I'm from the ACT Health Directorate team implementing the primary care pilot. In October 2022, the Australian government announced in its budget that there was funding for primary care pilots in all states and territories. The core objective of all of those pilots is to test innovative models to reduce pressure on emergency departments. In the ACT, we're going to use this funding from the Australian government to build on and support what GPs are already doing in primary practice. We want to do this because we recognise that GPs are at the centre of care for people with complex and chronic conditions who may need to use the emergency department more frequently than others, and that they have the capability to provide the level of care required. However, through this pilot, we want to provide some additional support for GPs and stronger integration with the hospital system to help facilitate ongoing and meaningful change. As I said before, the core objective of all pilots is to reduce demand on public hospital emergency departments. In the ACT, this means testing stronger integration between GPs and Canberra Health Services. Canberra Health Services will be providing care navigation and coordination support for any patients that participate in the pilot, and will work with GPs to undertake care planning and support their patients to receive the care that they need. We've received funding for the ACT Primary Care Pilot for 18 months. This is a great opportunity to trial some of the things that GPs have already told us would make a difference to help them care for people with complex and chronic conditions. Patients who participate in the pilot will receive 12 weeks of support through GPs and the Liaison and Navigation Service at Canberra Health Services. Liaison and Navigation Service is also called LANS, and Kirsty will talk about that in a bit. But LANS will work with GPs and patients to undertake care planning, health coaching, and undertake care navigation as well for people who have to navigate quite a complex health system. Things of note are that GPs who participate will have access to a virtual medical specialist advisory service. We'll be providing phone or virtual access to Canberra Health Services medical specialists in key specialty groups, so that GPs can talk to them about their patients and receive advice rather than having to always do formal referrals. Patients who participate will also receive timely access to community allied health services at no cost to them. The target patient cohort for the pilot is people who are at risk of requiring acute hospital services, where collaborative intervention, such as what the pilot has to offer, could reduce this risk. It's not for people who may need acute hospital services immediately or in the next week, but really for those people where we can see that they're deteriorating and know that there's something that we could do to intervene before that happens. To support this, we've developed a framework for how GPs will be able to select their patients to participate. The framework includes both risk factors and that they're likely to benefit from what the pilot has to offer. GPs will be encouraged to use their clinical judgment to refer their existing patients to participate in the pilot, and they can work with the liaison and navigation service to further filter their patients for participation. A key part of the framework that we'd like to encourage is that patients who where financial factors or other vulnerability factors exist can be prioritised to ensure that they make the most of the pilot offering, including the aspect of free appointments for the patients. We will be undertaking an evaluation of the pilot using an external evaluator. Participating GPs and practices will be asked to provide feedback during and after for these purposes. Patients will also be asked to provide feedback about their experience so that we can understand the success of the pilot. I think that's all from me because the next one is how to participate. Sorry, I'm just talking.
That's fine. Thanks, Emily. Thanks, Emily. So, Kirsty, if you are now happy to come on and talk about the Liaison and Navigation Service, or as we affectionately call it, LANS. Thank you.
Thank you, Kate, for inviting us along today to talk about the primary care pilot, and thank you, Emily, for your summary of it. As Emily said, we've sort of developed a bit of a framework around risk factors and likeliness for somebody to benefit from the pilot project. At the core of the project is the liaison and navigation service, as far as that connection between the various components. So I'd just like to say that liaison and navigation and the team here recognise the GP as the primary and ongoing care coordinator for their patients and acknowledge their expertise in these areas, but also acknowledge some of the challenges of developing and sustaining complex care management for their clients, particularly across the health ecosystem, and some of those challenges and barriers in connecting care and sharing information. So as part of the primary care pilot, we'd like to see if we can have a collaborative sort of relationship across various services as between those primary care services publicly available in community sectors, to see if we can assist GPs and their patients to have better outcomes and keeping people well in the community with less time constraints on them. So I guess part of the primary care pilot, as Emily said, has been built on some previous feedback that we've got from the GP sectors on what they think might assist. So this is what we've sort of developed into this pilot, is that liaison and navigation, where we could start to work with the teams on coordination, care planning, information sharing, integration across that really complex health ecosystem. We want to start to learn how to provide escalation pathways and keeping people well in the community. We want to support them to navigate those complexities and share care between hospitals, interstates, like interstate hospitals, community sectors, NGO sectors, and of course keeping the GP at the core of that sharing of communication. And of course, our ultimate goal is to hopefully reduce that avoidable emergency department attendance and avoidable presentations to hospital. I guess from a LANS perspective, we are building a team structure of a multidisciplinary team of nursing, allied health, and a GP support for a few hours per week to help with that connection between GP and CHS. The other components to the LANS service is we will do a intake hub to help with the actual administrative burden of trying to connect with non-GP specialists and trying to coordinate timing of that for your practices. And the other component that we will try and assist with is getting timely access to selected allied health, community allied health services. I'll just go to my next slide. I guess the land service is based around on key service principles of being person-centred, trustworthy, trauma-responsive, equitable and inclusive, dignity, strength, space and capacity building, and his ultimate goal is for that integration and collaboration between service providers. And we want to continue to build knowledge and relationship across our services to ensure we keep our patients healthy and well and connected. I think from me that's all today, but I'm happy to take any inquiries via email or questions if they arise through CHN.
Thanks, Kirsty. So now I'll continue. And just talk about Capital Health Network's role in this, what practices, their role in the project, in the pilot, sorry, and the expression of interest process. So just a quick introduction to Capital Health Network, or CHN. So we're ACT's primary health network and one of 31 PHNs across Australia. And we work to streamline and coordinate primary healthcare services in the ACT through collaborating with stakeholders and commissioning services to address needs in the community. So to start with, so you've heard the overview of the pilot from Emily and a little bit about the LANS team from Kirsty. So for this pilot, we'll be looking for a total of 15 general practices. And these practices will be onboarded in three monthly tranches. So the first one beginning in October this year, the next one in January 2024, and then the final one in April 2024. And ideally, we're hoping to onboard 5 practices in each tranche. So interested general practices who are interested in participating will need to familiarise themselves with the tender documentation, which is on our tenders page. Submit an expression of interest, and the link to do that is also on that tenders page. If successful, then sign a service agreement with CHN, and through that you're also committing to participate for the duration of the pilot until June 2025. So the role of the general practice will be initially to identify and refer eligible patients, contribute to and attend care planning sessions with LANS and the participating patient, agree to provide free at point of care appointments for pilot patients in accordance with their care plan, provide appropriate access care and referrals as necessary, access the phone and virtual advice that Emily has already talked about from certain CHS specialists, and participate in specialist shared care programs as appropriate. So to the patients, and Emily's covered this slightly, and on the tenders page you'll also find a patient selection guide which has more detail about eligibility. The LANS team may also identify patients who are frequent users of emergency department that may be members of your patient population and suggest them to you to enrol in the pilot. The patients will be enrolled in 6 3-monthly cycles, with around 5 to 25 patients per cycle and up to a total of 50 patients per practice over the length of the pilot. So once engaged and started in the pilot, practices will need to be enrolling patients each cycle, so every 3 months until the end of the pilot. Ideally, the patients are enrolled at the start of the cycle, but if required, they can join during the cycle if that's more appropriate. So the GPs will have identified their patients, they'll discuss the pilot with their patients, provide the relevant information. If the patient would like to go ahead, they'll obtain verbal consent and then refer to LANS on the provided referral form. LANZ will then make contact with the patient, they will obtain written consent, and they'll set up the care planning meeting that we've already talked about. At the end of the 3-month cycle, the patients will then transition back to the routine care of the GP. If they are still eligible, the patient may be enrolled for another cycle, and that can happen twice. And then to the funding. So each practice engaged in the pilot will receive a one-off administration block payment that will be upfront on engagement. This covers set-up activities, administration time, and the patient identification. Amongst that administration time, we allow for 10 hours of GP time, 7.5 hours of the practice manager's time, and 7.5 hours of the practice nurse time. There are then 2 engagement block payments, one at engagement and then one at 6 months of participation. Once again, these are one-off payments. In addition to that, there are per patient payments, which cover care coordination activities, time with the specialist advisory service, and attending the case conference. These are paid on patient enrolment and before the patients start in the cycle. As this covers time for the GP to attend a case conference, the GP should not claim their attendance at a pilot funded case conference through the MBS to ensure compliance with the Health Insurance Act 1973. Then in addition to that, practices must either select option A or option B and then stay with that option for the remainder of the pilot. Through option A, these practices will receive an additional per patient payment, which will cover 5 long appointments, and the practitioner would not bill the MBS for these appointments. Or through option B, the practitioners would agree to bulk bill the pilot patients for these the appointments in their care plan. For practices, choose selecting option A. If a patient requires more than 5 long appointments in their care plan, then these appointments can be charged in arrears at the end of the cycle. We also require the general practice to provide a percentage of the administration time for the GP that we talked about, the 10 hours, as well as the per patient payments to the participating general practitioner, as per standard business practice. We also recommend that multiple GPs participate from each practice to spread the pilot model equitably throughout the practice. And just to make things a little easier, CHM will supply a tracking sheet to assist practices with keeping track of where their patients are up to, but there is no requirement at all to use this. Reporting. We will supply a template and practices will be required to provide a performance report at the end of each 3-month cycle. This will cover things like the number of enrolled patients, the number and length of appointments, and information like that. Financial acquittals, which can be unaudited, are required every 6 months. And then, as Emily's already touched on, practices and GPs must actively contribute to the evaluation of the pilot. And that's including providing a good news story and any lessons learnt, if that's there. So to the expression of interest process, the EOI is open and will remain open until Friday the 5th of April, unless we reach the quota of practices, so that's 15 practices before then, in which case we will announce that as soon as we can on our tenders page. As I said before, we're seeking 15 accredited general practices in the ACT, and we will prioritise practices with a higher number of high-intensity users of emergency. So the important documents to read through is the tender documentation, the frequently asked questions, and I'll come back to that, the general practice information sheet, and the patient selection guide. If you do have questions, we ask that they are submitted through our tenders email, which is on the next slide. And then not only will we respond to those questions, but any questions will then be added to the FAQ document, which is then updated and uploaded to our website every Thursday. To submit an EOI, visit our tenders page, and that's the address on the bottom there. And the timeline, as I said, the EOI will open until the 5th of April, but may close earlier. We will aim to contact the practice within 1 week of submission of your EOI. We will then aim to finalise the contract within 2 weeks of submission, and then after that, practices will be assigned to and onboarded in tranches. There is an option in the EOI form to select a preference for which tranche you would like to be involved in. However, we can't guarantee that we will be able to accommodate that. So as we said earlier, tranche 1 will begin in October, tranche 2 in January, and tranche 3 in April, with 5 practices in each tranche. And there, any questions, please email tenders@chnact.org.au. And that email is also on our tenders page. We will get back to you, and we will also update our frequently asked question document every Thursday with these questions on our website. So thank you for joining us, and we look forward to your expressions of interest. Thank you.